Good evening, everyone. I'm Mike Barrett. I'm the president and CEO for South Bruce Grey Health Centre. I also have the privilege of serving as the co-chair of the Grey-Bruce Ontario Health Team. It just turned 7 o'clock, so we'll just give it another 30 seconds here, let people join in, and then we'll get things started with our presentations tonight. So why don't we get things started? Again, welcome. Thank you for joining us tonight. This is our fourth in a series of community information sessions that we've been holding, I guess, since last June, which came as a result of feedback that we received from the community about people wanting to learn more about the health system here in Grey-Bruce. So I'm going to provide the introduction tonight, and then we've got some great speakers, both on the public health side and the service provider organization side, which we'll introduce in just a sec, but I'll provide you with a short introduction here and welcome you all to the meeting. The next slide, please. So just some housekeeping before we start. Hopefully most of you have already used Zoom over the last 20 months as we've been going through the pandemic. If you haven't, if you have it up on your screen, just hover your mouse over the bottom of the black box and you'll see some menu buttons pop up. On the very left side is the mute button for your microphone. So we just ask that you keep your microphone muted while the presentations are going on. There will be a chance to ask some questions as we go through the process. If you're on the phone, if you're joining by phone, press *6 to mute or unmute your phone. And then it would be great if you want to keep your camera on. You can control that by the stop video button in the lower left-hand corner. Understand if you don't, but it's always great to see people's reactions when the presentation's going on and any inquisitive expressions that people may have as the presentations are going through. How we'll control the questions coming in, there's a chat feature. So if you can see in the middle of that menu bar at the bottom, it says chat. You click on that, you can type in your answer, type it back to everyone. Everyone can see your questions, and then we'll address those questions because others around the table may have the same questions as you. So again, please keep your phones or Zoom on mute if necessary, or as we go through the presentations, and then we get into the time for opportunity for questions. Feel free to open it up or put your questions into the chat box. So our agenda for tonight. So we're going to go through and do our introductions. We'll talk about the purpose of the information series, which I've kind of given the highlights on already. And then we'll get into the feature of the tonight's session, which is our presentations from public health and the service provider organizations. And as always, this is an opportunity for questions and answers. So please have your questions ready to go, and hopefully we'll be able to provide some answers for you. So before we start, just want to acknowledge the traditional territory on which we're holding our session tonight, acknowledging the Indigenous peoples whose traditional territory we get gathered on today. And I want to really acknowledge the long history of First Nations here in Ontario and show respect to them today through this acknowledgement, including the 2 First Nations here in Grey-Bruce, including the Chippewas of Nawash Ceded First Nation and the Saugeen First Nation. So in terms of introductions, I've introduced myself. My co-chair for the Grey-Bruce OHT is Hector. Unfortunately, Alex couldn't be here tonight, but Alex is the executive director of the Southeast Grey Community Health Centre, which is doing great things in eastern part of Grey County and centered in Markdale. The Engagement Sub-Committee is the group that's been coordinating and spearheading these community information sessions, along with a lot of other components of our work. Chaired by Stephanie Dudgeon from the Brockton area family health team. Steph has been doing a tremendous amount of work in addition to her regular day job to make sure all of these information sessions and other work around the OHT can progress. I won't go through the list of membership there, but you can see lots of people contributing their time to to make sure that we can advance the OHT and can help inform the communities here in Grey-Bruce about the health system. So the purpose of the information sessions, I've touched on this already. We heard back in the spring and even a year ago into last fall that people want to know more about the healthcare system in Grey-Bruce, not so much about the OHT, the Ontario Health Team, but just about how the health system functions here. So we've had, this will be our fourth session. We've had all different sectors, long-term care, home care, hospital, community mental health and addictions, bringing speakers in who are from those sectors to talk about the health system. So they've been well received. And again, this is another one that we're doing tonight. And again, we want to make sure that you have an opportunity to have any of your questions addressed. So I've talked about that, how you can get those questions either when the time comes, going off mute and asking the question or putting it into the chat box. So what is an Ontario Health Team? So how I describe this, every jurisdiction around the world is always trying to find the best structure system about how to operate their healthcare system, whether it's privately funded, which the majority of, or large majority of is in the United States, or publicly funded, which many, many countries around the globe do. But it's within the province of Ontario, we had the Ministry of Health to start, then the Ministry of Health decentralized to create 7 regions. Following that, we had district health councils, which provided planning advice to the Ministry of Health about how the health system should function. Then we had LINs, the local health integration networks. With new legislation that was introduced 2.5 years ago now, the government created Ontario Health and Ontario Health Teams. And what I say to people, Ontario Health Teams are really a great opportunity for a smaller geography, so a smaller geography like Grey-Bruce, to leave an input and impact on their own healthcare system. So it allows us, for the partners within Grey-Bruce, to work more closely together and ensure that those patients, clients, and residents are traveling through the system, that they have smoother transitions between partners. And if you've been on previous calls, you would have heard me say this. People have you get really positive satisfaction from people's interaction with individual organizations, whether it's their family physician, their long-term care home that they live in, or they've interacted with a hospital. Where people's frustrations arise are in those transition points or handoffs between those different partners. So that's what the OHT will help work to address those transition points and make a smoother transition for the public as they move through the system. And it's the diagram here on the left shows what the healthcare system looks like, diagram standpoint, where the patient in the middle, all those colored circles, they're interacting with different parts of the healthcare system, and it's up to the patient to navigate that system. On the right is what an Ontario Health Team would be, where those colored circles are the partners that provide care. So it could be hospital, family physician, community mental health and addictions. They are working together to provide that care collectively to the patient. So as opposed to having individual connections to the system, the patient has a more coordinated system that they can interact with. And this next slide will be hard to read, but it talks about and we'll post this information that you can access later. It just talks about the legislative framework upon which Ontario Health Teams have been created. So it's the People's Healthcare Act that was created back in 2019, which lays out what Ontario Health Teams would look like. So we have an Ontario Health Team here in Grey-Bruce. There's one in here in Perth, in Oxford, Elgin, all that level of geography is seeing Ontario Health Teams approved by the government. So our Ontario Health Team here in Grey-Bruce was approved by the Minister of Health, Christine Elliott, back on September the 17th. So it was good news for us, and we had a series of steps we had to take to get to that process, but we're very pleased that we got that. And now we've got a lot of work to do to ensure that we can continue to progress the work of the OHT. And there's a tremendous amount of work going on around the structure of how we come together as partners. I've talked about the engagement subcommittee, which Steph chairs. We have a planning committee, which is coordinating all the work of the OHT here in Grey-Bruce. It's made up predominantly of executive directors and CEOs of different healthcare organizations, has all sectors represented. So lots of good feedback there in terms of how the direction of the OHT will be set. We have a group looking at the arrangement, the agreement that will be put in place between these partners as we begin look to sign that agreement. This agreement will outline how partners will work together, how they advance initiatives, how they do project work, and how they address any challenges that may be faced between partners as they advance that work. We've also got great input from a physician and nurse practitioner council, really good involvement from our physician partners here in Grey-Bruce, which is a real benefit, as they say, play such an important role in the healthcare system. We have a board-to-board reference group, which is composed of health service provider boards of governors, so the board of a hospital or a community health center, they form up membership of that board-to-board reference group and provide us guidance with governance. And then the community council, and I'm doing a very quick overview here. The community council is made up of 10 patient, client, resident, family, and caregiver representatives, which we went out to the community looking for people to sit on that council. We had over 200 applications. We interviewed people, narrowed it down to 10. I'm sure can't see all the members on the screen tonight, but I'm sure many of our community council members are sitting around the table tonight and really appreciate their work. And they are keen to go, and staff is doing a great job getting them up to speed, orienting them, and making sure that we can hear their voice around the table. And we have in our year one of our OHT, we have two populations we're focusing on: frail seniors with a focus on transitions, and then patients and clients living with mental health and addictions issues. And we did a survey back in November of last year and asked whether those populations make sense. And you can see the green bars, those people that said yes, those populations make sense for us to focus on in year one. So with that, I'm going to pass it over to Steph, and Steph is going to provide the introductions for the main part of our presentation tonight from public health and our service provider organizations.
Okay, thanks for getting us started tonight, Mike, and thanks to everyone for joining us for this session. Happy to see so many faces on the screen and many familiar names as well. So there's many of you that have, I think, attended probably all the sessions that we posted. Anyways, before we get started, one thing that the engagement subcommittee did talk about, and we'll be asking for feedback on at the end of this evening's meeting, is whether there are any suggestions from the group for future information sessions. If there's any particular areas that people would like to learn more about and feel that it would be beneficial. So again, whether it's just related to the healthcare sector in general or related to the OHT, but that's just something that if you could keep that in mind throughout this evening, and if you have any suggestions, please feel free to put it in the chat box, and we will record that and take that back to the engagement subcommittee as part of our planning. So our first speakers tonight are Dr. Arra and Dr. Zayed, and they are coming from the Grey-Bruce Public Health Unit. So welcome to both of you, and I will turn it over to the two of you for your presentation.
Thank you. Thank you for having us. Good evening, everybody. My apologies. The internet speed in the location I'm in would probably give us a hard time if I open my camera. So I'll just leave it for voice now. And if we can go to the next slide, please. So the presentation today is just a brief description of public health system, public health mandate, and core competencies. And I'll cover a couple of slides there. Then I'll turn it to Dr. Zayed, who can go over the standards with a bit more details and the public health and population health approaches. If we can go to the next slide, please. This is rather rough depiction of the system in general and the health system. The main take there is in most countries, wherever there is public health system, it takes the shape of what you're seeing here, public health on the right, healthcare system on the left, and there's some overlap between them. And all that within the health system, and that's within the social political system. Different countries in Europe might have different relationship between these two systems, the healthcare system and public health. But in general, in the Commonwealth, except for the UK, I would say this is what it is. In the UK, public health system becomes the planning system for the entire system, including the healthcare system. So it has a different advantages, disadvantages, but that's where we're looking at. The overlap between these two circles, public health and the healthcare system, lends itself to secondary prevention. When people fall off the wagon, become ill, they go to the clinic, the primary care or hospital, and there is some role for prevention. But the majority of what we do in public health is before people fall off the wagon, before they become ill, in their early childhood, and the influence will be with a trajectory of 20, 30 years down the road to become healthier, to reach their potential. And in the recent, I would say, couple of decades, there's focus on maternal health, because that's where there is significant impact on the health of the child after they're born and they grow into an adult, and that's where the prevention happens, even primary or before primary. If we can go to the next slide, please. The public health system in Ontario has different mandates. They are part of the legislation, and the list is long. It's a busy slide, but it really impacts every sector we go in our life, whether it is a school or municipal housing, or a city or a park or any housing. And the effect of public health will be felt anywhere except in private residence. We get a lot of requests about certain things, and especially during the emergency, and the border is the private residence. If somebody has a private structure, that's where really we shouldn't influence. The influence happens in anywhere where the public can attend. And if we can go to the next slide, please. By the way, this busy slide will be covered by Dr. Zayed as well. After many of her slides will touch base on those mandates. And this is my last slide at this point. And this circle of emergency management, it's one of these mandates. And you would see 4 or 5 stages of the emergency response. Public health usually plays secondary role in emergencies, whether it's fire or flooding. Fire departments will take the primary role. In bioterrorism or in infectious disease, public health becomes the lead agency. And obviously the pandemic is just a major example of a complex event, and there's a definition for complex events there. The recovery part of the pandemic management is usually the most complex to bring people back to normal or modified normal, depending on the situation that is. And they usually flow in other circles. So the prevention and mitigation, there will be preparation for the next emergency or emergencies, and the lessons learned from this emergency will be implemented. Our programs in public health will have already been altered in planning and application. And sometimes we do a couple switching gears. The Delta variant, for example, moved us from recovery back to response. And I do believe the system in Ontario is very robust. And one of the major benefits we have, all of us, is the Health Promotion Protection Act. It's a readable act. If you happen to be interested, it doesn't need a lawyer to read it. And it was written that way because of the impact on the entire public. And It is a very robust tool and a beautiful document, in my opinion, and many people who work in public health and other sectors, because it ensures the health of the public is paramount. I'll turn it to Dr. Zayed, and I'll be available for questions right after.
Thank you, Dr. Arra. Good afternoon, everyone. Happy to be invited to this session, and I really appreciate this information session to the public. It's really a great initiative. I'm going to continue this presentation, and I'm going to talk about three things: functions and competencies of public health, snapshots of some important public health issues that shows briefly how things can be overlapping between community participation and between partners and public health. And the third part, I will talk about how public health operates and how the approach of public health address these issues. Next slide, please. So first, talking about the competencies and functions of public health. As you can see in these slides, it talks about some functions that are based on competencies of public health, which is population health assessment, health protection, health promotion, emergency management, public health surveillance, public health policy, and program planning and assessment and community collaboration. So these are the main functions of public health. And public health core functions may not be known before even to healthcare provider, I would say, and we touched upon that during the pandemic. But that was back from SARS crisis. Canadian reports such as Learning from SARS and NALO reports, the future of public health in Canada. Public health noted the need of a well-structured stewardship and that is indispensable in the health system or to prevent disease and improve the health of the population. Crisis teaches us over and over the importance of strengthened public health leadership role supported by Public Health Act and ministry plan deliverables. The core competence that we are talking about are based on public health sciences, assessment, analysis, policy and program planning, leadership, diversity, communication, and partnerships. Next, please. So this is a famous slide in public health world where we find the public health standards or Ontario public health standards. So you can see here in this, it is based on principle. It's like a pillar, like the 4 pillars of principles in public health standards include the need. So what is this population's need? The impact, so how is our intervention will affect this population, short-term impact or long-term impact. The capacity, do we have the capacity to do that? And how we can have the capacity to fulfill the needs and achieve the impact. And lastly, in these principles are partnership and collaboration. So if we don't have the capacity, who is our partners or stakeholder who will help us to achieve this? Then we have the second layer, which is the foundational standards and protocol, which is really our data, the population health data, the research knowledge exchange or knowledge translation, program evaluation, and these are one protocol which serve the base or what we call foundation of public health. Then comes the program and protocols or the operation part of public health, where we collaborate with our partner in primary care or Ontario, and also like Ontario Health Team. So we have chronic disease and injury prevention, which include chronic disease prevention, prevention of injury and substance misuse, and this is covered in 2 protocols. Family health, which cover reproductive health, child health, in 5 protocols. Infectious disease, which is infectious disease prevention and control, rabies prevention and control, sexual health and sexually transmitted infection, tuberculosis prevention, vaccine preventable disease, and these are covered in 11 protocols. Environmental health, which is food safety, safe water, health hazard prevention and management, covered in 6 protocols. Emergency preparedness, which is public health emergency preparedness that Dr. Arra talked about, including whatever is infectious hazard, bioterrorism. So we have this protocol covering different types of emergencies. Next slide, please. These slides cover the Board of Health. So the Board of Health at a local health system, every public health unit is governed by, have these governments of Board of Health, and there are requirements of these boards of health at a local level. They have their own corporate function to establish a strong public health leadership at the local health system. In the Board of Health governance, the requirement include monitoring and reporting, continuous quality improvement, performance improvement, financial management, and compliance. Next slide, please. Now I'm going to, in the next few slides, talk about certain snapshots of certain complex issues. So we know that with using our public health science and standards, there are some complex issues or weak issues where there are mixed factors, individual factors, socioeconomic factors, multiple factors, and there is no magic wand to really transform these complex issues in a short time to solutions, but we need to have short-term, medium-term, and long-term solution. So some of these problems include, next slide, please. We have, for example, maternal child health. This is really a priority based on our population health assessment, and we can have what is related to reproductive health and child health early on. Next slide. So these are our initial statistics as you can see in the region from 2012 and 2013, and how the monitoring and surveillance is very important. For example, for breastfeeding rates, it fell from 98% to 89%. That really showed the importance of continuous surveillance and data and monitoring. Now the recent data showed that in 2015 it rises to 94.3% on exclusive breastfeeding, and this also helped us to in the same time put the focal work on healthy growth and development, supporting a Grey-Bruce breastfeeding coalition at the 3 birthing hospital, as well as partnering with primary care sites. So this is really an important work that we are focusing on. Next. Another important issue is, again, the maternal mental health. It is really a priority. You can see that this has been steadily increasing the mental health issues related to maternal health. In 2015, there is 28.4% of Grey-Bruce women gave birth had mental health concern of anxiety, depression, and bipolar disorder or other concern. In Grey-Bruce, there is 24% higher than the rural rate and 80% higher than the provincial rate. The rate is increasing locally. rurally and provincially. From reproductive health report in 2017, there is some indicator that this is something that is required more focal work on it. And again, we can imagine also with the COVID and the issues of pandemic, how that will impact the maternal mental health. And this is one of the priorities in our strategic plan. And of course, this one of the also issues that cannot be solved in 1 year or 3 years. It really needs a long-term and continuous work. Next. Another important priority in public health is early development instrument, where we can, it is a validated tool where we can measure the ability of children to meet appropriate development, health, and well-being indicator. It is an important tool for physical well-being physical and well-being for the children in Grey-Bruce, and it is very many vulnerability can be related to decrease in this early development and can be of concern, especially with some focus on single parents, parents with financial concern, mom with postpartum depression, low-income households, sustainable baby, and that will require a sustainable baby and maternal-friendly culture. And I think this is also one of the main strategies that are of importance to work on and based on public health importance and how to approach that. Next. Smoking is an important issue as well. There are many public health programs focused on smoking and vaping across age group. It is declining. There are stable rate in Grey-Bruce, but it is one of the issues that we need, even with the decline of the percentage of smoker. This is a problem that requires a lot of work and continuous work. Next. Body mass index, it's again one of the important issues, increasing weight and how this is a gateway for many chronic health problems, and this is one of our focal interest as a public health issues as well. We are working and highlighting the importance that there is either 3 out of 5 residents in Grey-Bruce are either overweight or obese, higher than the Ontarian and the Canadian level. There is no difference between males and females. Youngest age category is lower than other age group, and we need to focus on obesity and overweight as a continuous public health issue. Next. This is something that is trending up and is as good, that we have active or moderately active individuals, 3 out of 5, and there is no differences in gender or age or region. This is trending up and it is increasing, and this is something that, again, if something is improving, we need to sustain the improvement and maintain it. So again, it's a work, it's a continuous work, but this is again one of the key work that we collaborate with partners with. Next. Another important issue is the heavy drinking or using alcohol, and it is like in the this is a main important question in community health survey, Canadian Community Health Survey, how often people drink in the last 12 months. And it has, for male, it is 5 and 4 if female, or more drinks in one occasion, so the binge drinking. There are some important questions on that part, because it is still, it is a very important issues. Next. Again, when we talk about the drinking, there is a sharp increase in charge laid with drinking and driving in 2019. So this is something like we have several indicators about use of alcohol, and it is a pronounced culture of there is a pronounced culture of heavy alcohol use. And in 2020, 2 populations with increased intake of particular priority are women and post-secondary youth. So again, this is one of the most important health problems that we need to focus on from many indicators. Next. Another important problem is unintentional injuries. In Grey-Bruce, there is a higher age standardized rate of unintentional injuries. Emergency room visit, hospitalization, and death are higher than other areas. There is injuries across the lifespan, and it is a strategic priority for public health, addressing the underlying factor. Again, it could be alcohol, obesity, physical activity. Community-based approach is essential for dealing with this problem. In 2016, the Asia standardized emergency department visit for unintentional injuries was the highest in the province, and for the falls was 70% higher. Emergency visit due to cycling is higher than other rural areas, while motor vehicle collisions are comparable to other areas. Next. There is also, again, when we talk about the injury here in rural areas and in Grey-Bruce specifically, is higher, 1.5 times higher than other rural areas. There is it's high in 65 plus age, and which constitute also 23% of the population. And it is significantly higher than the provincial average. And again, this is one of the strategic priority of public health. Next. This is the type of again, in this slide, we can see I talked about that unintentional injuries, the falls, and it's mainly in 65 plus. The motor vehicle is comparable to other places right now, and a pedal cycle injury is higher. Next. Another thing that if we talk about social determinants of health or the acquired factor that can be controlled, like eating, health, level, education, income, and employment. So this is one of the major focus of public health, to invest in what we call upstream investment. So this is an important to have this information on a regular basis, because this will help us to see what are the main social determinants that are affecting the health of the population. Next. One of the main issues also that we are really having a high interest and focus on is the housing, either lack of the house, homeless, or lack of housing, or inconvenient housing, or again, there are also some other social issues related to housing, like, for example, house overtaking, which is some of the problem that also public health have highlighted, and we are working on getting more data on that with our partners. It is really an important thing. If we talk about also children and early development and how the housing condition can affect early child development. So this is again one of the very important upstream investment, and we have seen how this is by itself as a social determinant of health. People can turn a corner when they are provided with good housing in every way. Next. Transportation and access also is an important part and important either for access and or from a collision point of view or injury point of view. So it is also an important factor, and how it is also linked with income, with education, with age across the age, either youth or older adults, and how really it helps people to access services. So it is also one of the social determinants of health that we are focusing on in our strategic plan. Next. Food insecurity is definitely something that is also we are working on. Our chronic diseases and nutrition are part of chronic disease prevention. Main issue or main focal point is food security, and it is either quality and quantity of food. So a lot of public health work also is focused on this issue across the lifespan. Next. And again, this is nutritious food basket and how it is calculated based on the income and the cost, and again, this is an important part related to income and awareness. Next. The third part of my presentation will be focusing on, we talked about problem, we talk about the mandates and our protocol, so how we are approaching the work in public health. So it is important to have this working as collaborative and in a collaborative way. There is value in the population health view and effectiveness and quality and safety using the data. So this is our main pillar here, data about the problems and about the population demographics. There is also the emergency part, which is related to health protection and infection protection. And then there is the social determinant, or understanding which part of the social determinant is affecting these public health issues. And when we talk about that, it's important to talk about equity. So one of the foundational standards of public health is related, one of like independent one is equity. So embedding equity in every public health issue is very important. And so equitable access and sustainability, and also other public health, other issues, social determinants of health related to employment and housing. And then the health improvement part, which is intervention of healthy environment, healthy workplace, strategies and policy. And strategy and policies here are healthy public policy, which is putting public healthy, the health of the people wherever they are, in putting some policies that can help them having a healthy environment. Next. So again, when we talk about healthy in all policy, there is also that framework that is important for us. It's called Health in All policy. It's an approach to better the health and well-being of everyone through shared vision and decision-making across all sectors. It's about considering the health impacts of all policies, program and service, and working together for positive change. And this is like how to put the health in every place or in every place or service across the population where they are, and how, for example, this policy can affect the institutional change to a healthy environment. For example, putting some healthy policy for physical activity in a workplace. So this is some healthy public health policy. Embedding equity in action and putting this as a consideration. You see here how in this framework, the health equity is really in the center position. And this is one of our strategic plan in public health, and one of our metrics when we work in different sectors together. We have the equity parameter as one of the main factors in any kind of strategic plan or operational plan. Next. Again, when we talk about equity and when we talk about the health needs and population health assessment, one important work for public health is health equity impact assessment. And when I say that the equity is a focal part, so how we can assess the impact, putting equity in consideration. So we usually have this health impact assessment. Is it needed for this health problem? And then scoping the impact, is it positive or negative one? And what is the current status and recommendation? And we put this recommendation and then reporting to partners. And after we report and sharing results, we can monitor and evaluate the implementation over time. And so that is a measured impact or measuring the impact of applying certain assessment or result of an assessment or over the population. Next. And this is a very important also intervention. So this pyramid is a 5 tiers pyramid that shows us which part that has the highest impact on the population. So when we work on the socioeconomic factors that I mentioned before, like income, employment, education, and housing, this is a main area. We can see that how this is increasing the impact on the population. If we change the individual decision by default to be healthy, it has an impact. And then long-lasting protective intervention, clinical intervention, counseling, and education. So we can see that counseling and education has less impact than working on in this base of the pyramid on the socioeconomic factors. So the more impact will be at the base when we talk about population, which is a public health function, which is different than individual effort. So when we talk about individual effort, the increase in individual effort will be by individual counseling and education. But if we talk population impact, population-wise impact, we have to act on the social factor or invest in this upstream level or the base of the pyramid. And again, some public health complex issues that I mentioned, we need to work on these 5 tiers together, or maybe simultaneously as well. Next. And this is the last slide of the population. So as I mentioned, the population health approach is important and the impact. So we have public health utilizes this approach, that the approach over the whole population. So the first, so it is an eight steps for population health approach. So focus on the health of the population, address the determinants of health and their interaction. So how income interact with housing, with physical activity or healthy weights. So address this determinant, based decision on evidence. So usually our evidence-based are on foundational standards that we have, and the data that we get from surveillance and population health assessment. Increase upstream investment, apply multiple intervention and strategies, as I mentioned in that 5 tiers pyramid as an example, collaborate across sectors, employ mechanism for public involvement, and this is how we communicate with the public, and their feedback and is important when we assess the needs and the impact, and then demonstrate accountability, which is continuous monitoring and evaluation. And with this slide, I came to the end of my presentation. Thank you.
Okay, thank you, Dr. Arra and Dr. Zayed. So I think in the interest of time, we will hold off on all questions until the end of both presentations. And also know that any questions in the chat box, hopefully we will get to all questions tonight for those speaking and anyone that enters something in the chat. However, if we don't, we do send out recording after the session, and it does include the Q&A and responses to any questions. So we will ensure that any questions that the group has do get answered. I think we will move on to our next presentation. So we have Jody Phillips here with us tonight from Care Partners and Angelica Gallnell from Closing the Gap Healthcare. So I'd like to welcome the two of you. Thank you for joining our session this evening.
Thank you. That's great. I'm going to start, and then I'm going to pass things over to Jody. Can someone just give me a thumbs up that you can hear me? Okay, thanks, Mike. Is someone advancing the slides? How did you do that, Rim? Ah, perfect. Okay, magic. So Closing the Gap, VON, ProRes, Paramed, and Care Partners are the 5 home care service provider organizations that provide home care to the communities of Grey and Bruce. And, you know, there's a couple of things that we hope that you take away from our presentation today. And I'll just say, I have worked in multiple parts of the healthcare sector, and home care is truly one of the most complex to understand. So I hope that Jody and I do a good job of unpacking it a little bit for you so that you have a better understanding of how we are organized. So one of the things I hope you take away from today is that these 5 organizations were all founded in the early 80s or early 90s. We've been in the Grey and Bruce communities for a very long time. You can see from this slide our addresses in the community, and that and Jody's going to speak to the total numbers of team members in the Grey and Bruce communities, but our team lives and works and are members of the Grey and Bruce community, so we really feel very much a part of the Grey and Bruce communities. I'll go to the next slide. So, you know, one of the complications of home care is that we are ever evolving the way that home care is managed and delivered, generally with the hope that we get it better and better. But ever changing the way that we deliver home care comes with some challenges as well. So I'm going to just highlight a couple of these dates. This is a very high level summary because we didn't want the slide to be too busy. But fourth from the left is the date 1996, which was the establishment of 43 community care access centers, which we affectionately called CCACs. And a year later, in 1997, managed competition in home care was introduced. And this is really where service providers built their relationships with the community care access centers. And the role of the community care access centers, and Jenna Prouse, who is our fearless leader in our in the home and community care space, can answer any questions related to what were then called the CCACs, and I'll tell you what they're called now in a minute. But the basic role of the CCACs are to manage a competitive procurement process to identify organizations that can deliver nursing, personal support, and therapies, occupational therapy, physiotherapy, etc. So those staff are not employees of the community care access centers. So the first role is to manage the procurement and the competition of identifying who the nurses and personal support workers will be in the community. The second job is to manage the intake and assessment of new clients and refer those clients, as well as care plans, so the numbers of visits that each client will get. That information comes to the service provider organizations. And the third job that the CCACs have are to manage long-term care home placement. And there are many, many other things that the CCACs did and do in their most recent iteration. I'm just giving you a high-level summary. But in 1997, what really changed is that the CCACs had a competitive procurement process. And the result of that was that as in Grey-Bruce, we identified 5 service provider organizations, and we have contracts with, at the time they were called the CCACs, and the contracts were made up basically of 3 things. The first was where you are providing, what communities you are providing service in. In some cases, it might have been just Grey or just Bruce as an example. The services you will deliver, and sometimes it would be a combination of personal support and nursing, or just, as an example, personal support. And the third thing was the percentage of the share of the community, of the referrals for the community that you would get. So in some cases it would be 50%, in some cases it's very small. So those are the 3 elements of the contracts that we have with what were then called the CCACs. The reason I'm telling you all that is because not so long after the competition in home care was introduced, in 2004, a moratorium was called on all new contracts. And again, I'm very much oversimplifying, but essentially we have not moved past that and still have the essential contracts in place, or we are using the same contracts that were in place in 2004. They have not changed, with the exception of amendments when brand new service or program areas are introduced. Otherwise, our market share, the geographic area we serve, and what disciplines we provide, that has not really changed since 2004. The one other thing I will say about this slide is that I'm just going to skip to the far right and say that we no longer have CCACs. We did a whole bunch of changing between 1997 and today, but now there are 14 home and community care support service organizations, no longer CCACs. And as are all things in healthcare, we have turned that into an acronym, which is HCCSS. And I guess the last thing I'll say is that all these changes make it really difficult for us to sustain innovation. It means that oftentimes staff are frustrated and leave the sector, so we lose historical knowledge. So constant change, as I'm sure you can appreciate, has been somewhat difficult for the sector. I'll go to the next slide. Thank you. So I've basically spoken to the first 2 points. So I'm going to go to the third bullet. And as I mentioned, HCCSS, previously CCACs, send service providers referrals. So we get our new clients between 8 a.m. and 8 p.m. And we have a limited time to accept the referral before it times out and gets sent to, if we have 50% of the market share, if we can't accept that referral, it goes to the next service provider organization who has let's say 25%, until somebody can accept that referral. And we have a very short time, so we have to identify for nursing, it's within 30 minutes, we have to identify a nurse who can do that visit in whatever the time period is that we've been given to see that client, and 45 minutes for personal support. So that's a constraint that we deal with on a daily basis. The other thing that I want to point out is that we have a fee-for-service structure, which means that we are able to pay our employees, the nurses, the personal support workers, for each visit that they do. And we have a specific rate that we are paid for that. And the challenge with that is that unlike other organizations in healthcare that receive a global budget, it means that you have your budget for the year, you more or less know the dollar amount that you're working with, and you can more easily and flexibly adapt when supply or demand for your services go up and down. Whereas in our situation, if we're not able to give, for example, a personal support worker a lot of work because we haven't gotten a lot of referrals, that personal support worker, he or she may decide to leave and go do something completely different. So we've lost that person from our human resource pool. And alternatively, if suddenly the demand for our services goes up, we might not have the capacity in our pool of employees to meet that demand because we just don't have the budget capacity to have staff on who aren't working 100% of the time. I hope I explained that well because it's kind of complex. Okay, we'll go to the next slide, please. I think actually I've talked about all of this. I think the only thing I'll say is that we've also not, I sound like I'm complaining a little bit, but it's a tough space. I think I've talked about all this. So Jody, I'm going to pass it over to you and you're going to talk a little bit about who we are, where we are, the numbers of our staff, and really sort of get into what it is we do. So over to Jody.
Yeah, that's great. Thanks so much. And you're absolutely right. It's people think we're a simple sector, and we're actually really a complicated system to work within. So if we want to just move to the next slide. So Angelica mentioned market share, and so the way in which we divvy up the geography is based on the geographical stream, but then beyond that, a percentage allotment. And so for Grey and Bruce, we split the various types of services up based on a market share. And so for Grey and Bruce visiting nursing, we have 55% of all the referrals go to care partners and 45% to VON. For shift nursing, care partners is 100% of the shift nursing volume. So every referral that comes forward from home and community care for a shift nursing patient comes directly to care partners. For personal support, we share that as well. So care partners has 50%, and the other 50% is serviced by VON and Paramed. Closing the Gap has services OT, PT, speech language pathology, nutrition, and social work. So they receive 100% of the referrals associated for Grey and Bruce. And so the challenge with a market share is that it is a moving target. And so when we talk about a piece of pie, say we have a full pie, 55% of the pie goes to care partners, 45% to VON. If that pie gets bigger, the amount of pie we have is greater. And so even though the share doesn't change, the actual volume changes. So when we talk about a market share, we know the percentage, but when that total goes up, that can be unpredictable. The reverse is true as well, where it can contract. And so these are some of the challenges that that managing in a fee-for-service or unit of service model can create for us. The next slide sort of gives you a picture of what we represent in terms of total staff numbers. So this is collective through all of the organizations that deliver services currently in Grey and Bruce. It divides it out for you, but these are 266 employed individuals who are residents of Grey and Bruce counties, serving the health system under the umbrella or auspices of our respective organizations. So sort of gives you the breakdown of that. And we gave you sort of every type of employee, so the therapists, the PSWs, nurses, but also management admin staff. So we're a pretty considerable employer when we look at our entire sector. Next slide. Just to give you an idea, home care is not, it's one of the reasons why I think it's challenging to understand what home care is. It isn't a destination, right? We're not going to a bricks and mortar to receive care, although you can through a clinic environment. Typically, our service is delivered on an individual one-on-one basis in a patient's home. And so when we look at the number of visits that we deliver, in September, number of visits looked at 8,594 visits. That's giving us probably an average of 10 visits a day for every nurse that we employ collectively in the region. And at the moment, we actually need 29 additional full-time staff in the region. Personal support, we delivered 10,433 visits, and we are short 43 full-time staff within Grey and Bruce. Therapy, no different. Volumes are obviously smaller, but still have the same proportional needs. So 1,600 visits and 8 vacant staff. When we look at the number of visits that nurses and personal support workers or therapists can do in a day, they're hampered in this geography because of the sheer size of these counties. So we certainly organize ourselves in teams, regardless of which SPO we're talking about. We organize ourselves in teams in order to facilitate seeing the largest number of patients in a day, but there are certainly limits in terms of what can be accomplished over the course of a day. So for care partners, we work 12-hour shifts. Typically a nurse in Grey and or Bruce would see 10 visits a day, and a personal support worker likely is more like 8. Nursing visits are a little bit complex in terms of deciding how long any one visit might take. Personal support is a little more predictable with an assigned actual time for that. Therapy, give or take, whether there's an admission, we're probably looking at more like 7 visits per day. The next slide kind of shows, again, complicated levels in terms of, oh, sorry, I must have missed that slide in my deck. So this is really showing you a day in the life of a nurse. And so when you look at the right-hand side, that's sort of showing all the points that that nurse has traveled throughout the day. It equates to approximately 200 kilometers and three hours of driving, in addition to the number of patients that they've seen. So the split is depicted in the circle that shows how much time of that particular day was spent delivering actual patient care. It's important to note that we're paid based on patient care delivery. So there is no additional compensation associated for the organization to compensate us for the additional travel costs. So we've got rates that are established for our contracts that don't take into account the fact that we have a nurse that drives 3 hours. And this is quite frankly a typical day. So next slide. So this is sort of gives you a bit of a snapshot to demonstrate the types of volumes that we do at any given month. A few things I'll just point out. certainly we had an impact when the pandemic hit, as did all of the health system. Certainly our volumes typically fluctuate. We have some months that are 30 days, some that are 31, statutory holidays, depending on the home and community care. You may or may not be receiving care on a statutory holiday based on those policies. But we know that there are periods of time where surgeries are down. And so when surgeries are down, Angelica can expect probably fewer referrals for therapy. Speech language pathology, typically summer months, there's a contraction of volumes there. And so there's certainly those opportunities where there's fluctuation. I would call some of that natural fluctuation that is somewhat predictable. But I think what we're trying to show you really here is that although the pandemic has certainly hit the health system very hard, we continue to see many patients in Grey-Bruce, despite our 29 fewer nurses, 43 fewer PSWs, and 8 fewer therapists than we would prefer to have. So it's just kind of showing you our road to recovery post-pandemic. Next slide. We wanted to give you a bit of an idea of what we do in home and community care. I think there's some confusion sometimes. People haven't had direct experience with home and community care, and so there is really a wide variety of services that we provide in any given day. Our nurses, therapists, and personal support workers have to be trained to allow them the flexibility to service a wide range of patients. So, we administer intravenous medication. We do palliative care, which includes medically assisted dying, wound care, dialysis, various types of tube care, chest tubes, trachs, wound drainage tubes, etc. So it's a wide variety of things that we do. Although wound care in nursing is a big portion of what we do, and certainly palliative care, we do a very wide variety of services for patients. Typically, nurses are assigned in teams, and so their skills are reflective of the patient care delivery that they are servicing, and so would have all the skills necessary to manage these various types of illnesses. In terms of therapy, on the next slide, again, there's a wide range of services that are offered through therapy programs, mobility, home safety, home assessments, seating assessments, pain management, stroke rehabilitation, mobility aids, etc. In our therapy programs now, we also have services that are delivered in other settings beyond just in-home. There's an ARCHES program and a transitional bed support program that Closing the Gap provides therapy services through. In addition, next slide, we talk a little bit about dietetics and all of the various things that dietitians would provide services to. Again, looking at wound healing, renal impairment, stroke care, palliative care and support, social work, adjusting to illness and disability, coping behaviors, basic needs not being met. So things like food, shelter, and finances that we talked about in the public health presentation. Next slide. The 4 service provider organizations do work very collaboratively together. We have a very strong working relationship with home and community care support services and have enjoyed that relationship for many years. Home care sometimes gets a bit of negative press. I can assure you it's certainly not the people within those systems that are somewhat challenging. Our system, just like every other part of our health system, is very political, and the structures often often are the barrier to achieving what we all want for our health system. And certainly home and community care is not unique in that regard. So as I said, we do work very closely together. We put forward ideas and concepts that will help us all achieve what we want. And I have to say, I work with all of the home and community care organizations across the province. And I would suggest that this is probably the strongest relationship, certainly that Care Partners has in the Southwest region. This home care program does recognize the challenges and are not sitting around waiting sort of for those changes to happen. We're working within the structures that we have to try and impact. And part of the reason is probably areas such as Grey-Bruce, who are sort of experiencing the early impact of the health human resource struggles. So as such, we've been able to take on a number of initiatives to try and assist in more innovative ways to increase the number of patients that we serve. So we've included a few of those ideas and opportunities here. We did establish early on in the pandemic a clinic model that allowed for some predictability for our nursing staff. So we need to deliver 12 hours of service in these clinic settings. However, we never know for sure that we're going to get 12 hours. And so we've worked to set up new models to help create that predictability for employment of our nursing staff. We've also partnered with home and community care to develop an e-shift model to deliver services to patients who perhaps would normally be receiving care through a nurse in the home, but now receive a PSW in the home and a nurse supporting remotely using a virtual care application. E-shift has its roots in this region, and we're certainly very proud of the work that's happened there. Again, e-shift, there was a lot of challenges in retaining staff, and it also again goes back to the lack of predictability related to the volume of work that comes forward. A palliative patient can die, and there'll be not work to replace that, and so the turnover was significant. These are highly trained personal support workers and delegating nurses, and so home and community care allowed us to shift the e-shift model into a new program with the same basis, but it's a hospice, virtual hospice bed that allows us to create that ongoing flow of patients. And so now what we have are a number of beds associated with Grey-Bruce that are filled on a regular basis. The Intensive Personal Support Services program does allow for more services to be delivered to those more complex patients. And this is really designed to either one, get patients out of hospital, or keep patients from having to go into hospital. We certainly on an ongoing basis look for opportunities to improve the flow of information or the sharing of information amongst providers. Inclusion of home care teams in early acute care discharge planning. So those warm handoffs are certainly important to us as they are for other parts of our system. The sharing of care plans with primary care and community support services. So these are all things that Ontario health teams are attempting to address and will certainly benefit the home and community care patient as they flow from one part of our system to another. Reducing attrition turnover through funding parity across sectors. So this is an area that's been an ongoing problem for as long as I've been in the home and community care setting. And part of it goes to the fee-for-service model, and part of it is our evergreen contracts that don't really allow for regular increases to our rates. But generally speaking, personal support workers, nurses, therapists working in home and community care are paid less than those that work in other settings, so long-term care, hospital. And so it certainly makes it challenging for us to continue to recruit and retain staff. And certainly we're all in that boat now. All parts of the health system are challenged with health human resources. But I would suggest our period of time struggling has been somewhat longer, and our solutions to getting to a place where we can be more competitive have not surfaced. And so we tweak with models, we try and sort out new ways of using that fee for service to pay for more. There's only so much efficiency you can get when you're delivering one-on-one care. And so certainly clinics are helpful to that. But we're limited to what we can save in order to give more to the frontline staff. So those are sort of the innovations we've taken on to try and help address those, but certainly there's more opportunities that present themselves. And I know I speak on behalf of all the service provider organizations to say that we are ready, willing, and able to help support the work, important work of the OHTs across Grey and Bruce, and look forward to seeing some of these opportunities come to solutions around what ails our system. So thank you very much. We appreciate the opportunity to present here today, and I'll turn it back to the team.
Hey, thank you, Jody and Angelica. Thank you for sharing what the complexities of the home care system is and that structure. I think that it's widely known that there are challenges with home care, but I think that you've really provided some meaningful information about what those challenges are. And it is indeed, I know that you did a high-level presentation, but it's very complex. And so these structures that you're working within are not easy.
No.
So we have a couple of questions in the chat box, and I'll also open it up to the group to see if there are any questions for the service provider organizations or for the public health unit. Maybe we'll get started with the questions in the chat box. So the first question was from Rosemary, and it is for public health. And it says, Princess Margaret Hospital has been called the Beaver Valley Cancer Valley. Is it public health purview to campaign against the use of cancer-causing pesticides here?
Thank you. I'll take a first step at it and turn to Dr. Zayed if she needs to add to it. So anytime there's a potential cluster or real cluster, perceived or real, of cancer, there will be a process of investigation of 4 steps. Thorough investigation usually takes place publicly. So there will be discussion with the municipality and with the public and with the partners and with every step. And those are done nationwide, and there is a registry for cancer. There is Public Health Ontario that identifies these potential clusters, or sometimes comes from complaints from the community. Almost all of these investigations, almost all of them, rarely ever, that reveals a true cluster. Many people might not realize that 1 in 2 Canadians get cancer, develop cancer in their lifetime. 1 out of 4 dies of cancer. So it is very, very common. And there are many reasons for these perceived clusters. Could be very well the healthcare system screening process is very adequate. So you identify more cases in a local geography of a hospital or a screening program. I'm not aware of cluster or perceived cluster in that valley. Then you take a step further from different point of view. I'm aware the valley is agriculture, usually most often than not apple farms, which is the same industry across Grey-Bruce. So if pesticides are causing this excess cancer, why would it be in this valley, not the rest of the the geography. And I hope I'm not being perceived as dismissal of this. Rather, we have robust systems in Ontario, and it's not credit for myself or my team. And if there is any signal of excess, it will be definitely investigated and will be communicated to the public. Not sure if Dr. Zayed would like to add anything there.
Thank you, Dr. Arra. I just want to add also that we are taking environmental health very seriously, and there is mandates and frameworks that we are conducting. And as Dr. Arra mentioned about the cluster, it apparently can look like there are increasing cases, but any cluster we are seriously like assessing it. The other thing is there is a very important framework which is related to the exposure assessment. Is there a real exposure? The dose exposure, there is some threshold. Is it above the threshold or not? And then there is a risk characterization by environmental health and risk management if there is a characteristic high risk, and risk communication. And one of the mandate is communicating that risk, if any. So I want to assure the public that this is really taken as a part of integral part of our work. I have been working before in Saskatchewan in the north, and there was this mine work as well, and the nuclear like exposure. And I have a great expertise in this part, and I want to assure you that this is something that we are really taking seriously.
Okay, thank you. So the next question from the chat box is the public health standards slide showing program standards and protocols made no mention of senior care or long-term care protocols and standards. Is this need not also part of public health as our population is aging?
Thank you for this question. Public health standards are two types. Program standards, they're focused on the program level, and foundation standards protocol. Both of them, both sets of standards actually touch base and affect the health of seniors throughout. If I may ask to put the standards up, and I just can walk you through them. They're not the granular level where you will mention the age or the group affected. So if you can, I would appreciate if you can share the screen on slide number 7 on our set, I believe it was. If you wish, I can share my screen if that's easier.
That be easier, Abigail?
Yeah, just having a bit of technical trouble.
Are you? Yes.
Would I be able to get the thumb up if you can see it? So can people see the slide?
Yes, we can.
Okay. So, for example, foundation standards, this bulk here, population health assessment surveillance, definitely will capture any health need in the community, and the senior need could be in the long-term care facilities itself, or in the community, or in the activities. Whenever you walked through a traffic light back in the day, there was the window of time for it to turn from red to green or opposite was too short for a senior to cross the road. And this was captured in health assessment in different cities. Then you widen it a bit, you make the city more friendly. So again, this population health assessment will definitely capture many aspects of it. If you go up to program standards, emergency preparedness, infectious disease, real life example that we all could be proud of here, and we are proud of it, Grey-Bruce, there has been 0 death in long-term care. And that didn't happen as a coincidence. It's all these sectors around the table, including the standards to meet with the operators of long-term care early before the pandemic and during the pandemic and say, those are the standards that we need to hold ourselves up to. And you know, legally, legislatively that I referenced to, I mentioned to the operators that if things go the wrong way and you followed all the directions and the standards, I can defend you in court. And you know, the results stand for themselves. We have 0 deaths. Environmental health, that affects many facilities, the food safety, family health, the family effect on socialization within the long-term care or outside the long-term care, and the visits, and all these things are captured here. And they're not granular level where we're going to spell out everything, but they are definitely there.
I just want to add, sorry, I just want to add something, that most of the protocols or the standards are across the lifespan. So every protocol has some focus on some age group, but of course the old age and seniors are a high priority. And as you see that when I talked about also the injuries, and the prevention of injuries is important. And what Dr. Arra is mentioning about the light, the traffic light and speed and changing of the light, this is a healthy public policy, actually.
Okay, thank you. So we do have another question in the chat box. However, unfortunately, we are out of time for this evening's session. But like I said earlier, we will be posting the slides from the presentation and a recording, and also Q&A. So there will be a response to that coming out. So thank you to everyone for coming, and I'll hand it back over to Mike for final words.
Okay, thanks, Steph. Just a couple of closing comments here. Big thank you to our presenters. Dr. Arra, Dr. Zayed, Angelica, Jody, great presentations, and it shows you the complexity and the breadth of the healthcare system across the country, across the province, and here in Grey-Bruce. And this is the challenge of OHCs, is how do we bring this all together to ensure we're working more closely and collaboratively. So we've got a great healthcare system in our province, in our country, and this is all about enhancing the healthcare system that we've got. So a really big thank you to our presenters. I need to thank our engagement subcommittee who has put these sessions together. This is our 4th of 4, as I've said, chaired by Steph Dudgeon, who's been chairing the presentation part. So a big thank you to them. All of the people on that committee have their regular day job, you know, working and running their own organizations, and they're doing this to ensure that we can continue to provide great care to our communities. Also, a number of our people in the audience today are members of our advisory council. So our community council members, our board-to-board reference group, our nurse practitioner and physician group. So a big thank you to them. And mostly a big thank you to all of you who have joined in tonight. So you've taken an hour and a half of your time away from your families and friends because you care about the healthcare system. You want to learn more about what's going on here in Grey-Bruce. And that means a lot to us. So we'll continue to engage you. We don't have a 5th session planned. We've done most of the sectors across the healthcare system, but we'll continue to have engagement opportunities going into the future. So watch our website, social media. We'll make sure that the information comes out about future sessions, and we'll continue to keep you engaged and give you an opportunity to ask us questions as well, because we want to answer any questions that you may have about the healthcare system. So with that, if you do have any follow-up questions, there's a contact information on the Grey-Bruce Ontario Health Team website, so you can reach out to them, or to us, I should say, and we'll make sure your questions get answered, and just stay tuned for future opportunities for engagement. Okay, thanks everyone, and have a great evening.
Good night.